Alhamdulillah wa salala rasulillah. Assalamu alaikum wa rahmatullah. This is Dr. Amber Khan. I am the chair of the IMANA Education Committee for IMANA. I would first like to thank you all for tuning in. We have several webinars lined up for this summer, and we hope that you will stay tuned to check them out. And please let us know if there's any particular topics you may be interested in learning more about, as we can contact those who would be able to host a webinar for us. Tonight, we have a very important topic on understanding palliative care. We will be discussing through Dr. Natasha Piracha the basics of palliative care, who it benefits, the physician's role in regards to the care throughout the critical illness, and we will also be getting to hear a little bit more about special attention in regards to the understanding of hospice. I would like to introduce Dr. Natasha Piracha. She recently completed her fellowship in hospice and palliative care and palliative medicine in June at the Icahn School of Medicine at Mount Sinai in New York. So congratulations to you on completing. She completed her medical school at Rutgers, New Jersey Medical School in Newark, and she went on to complete a combined internal medicine and pediatrics residency back in 2014. During that time, she served as chief resident for the Internal Medicine Pediatrics program and subsequently as a chief resident in internal medicine at the East Orange Veterans Affairs Hospital. Dr. Piracha has also volunteered on 4 international trips with IMANA Medical Relief, Jazakallahu Khair, and she most recently was a team leader for the Save Syria mission last year on April 2019. So I'm very excited to introduce Dr. Piracha. Please, Dr. Piracha, please begin whenever you are ready. Thank you.
All right, sounds good. Jazakallah khair. Bismillah ar-Rahman ar-Rahim. Thank you again for the introduction. So I'm hoping to cover kind of a broad topic, which is just the basics of what palliative care is. And hopefully answer any questions that you guys might have towards the end that I can answer to the best of my ability. So I have no financial disclosures. And the outline, really, we're going to spend some time talking about definitions, making sure that we're all on the same page. As Amber said, kind of what the role is of palliative care in the illness trajectory. The benefits of early integration of palliative care, which is a big push that palliative care has had for a very long time now. The differences in primary versus subspecialty palliative care, some tips for approaches to palliative care in the primary care setting, and at the end, we'll briefly talk about hospice, and hopefully I can share some tools along the way. So we can do this 2 ways. The chat box is open, and if you're not comfortable kind of chatting through it, I'm wondering if everyone wants to take a minute to just think to themselves, when you hear the words palliative care, what do you associate it with? Now, take a pause there to let everyone have their thoughts. So I'm seeing some comments about end-of-life care, which is typically what we'll hear. Also hear the words dying or hospice. And sometimes people that have more exposure or are in institutions that have broader palliative care might think of things like pain management or symptom control. And it's really a myriad of those things. So the WHO defines palliative care as an approach that improves the quality of life of patients and families facing the problems that's associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And the Center for Medicare and Medicaid Services defines palliative care very similarly, patient and family-centered care with a focus on quality of life and a focus of treating suffering. And suffering has many definitions that we'll go through, but involves addressing the physical, emotional, social, and spiritual needs of a family and really facilitating patient autonomy. So just for any students or trainees that we might have on the video. So palliative care is a 1-year subspecialty training that is done after your residency. It can really be done following most specialty trainings, including internal medicine with all of these subspecialties. So you can have finished, critical care is a common one, or nephrology is a common one, and then go on to train in palliative medicine. Pediatrics, of course, MedPeds. psychiatry, OBGYN, etc. And there are some that are not listed here. Currently, the board exam is offered every other year. So the next time that you would take the board exams would be in October of this year, and those are offered through ABIM. Palliative medicine programs nationally can be quite small, maybe a couple of fellows, and it includes training in hospice medicine as well. Now we're going to take a step back and look at serious illness and really what the patients go through. I think that it's really common as physician practitioners, especially, to see the data, see a diagnosis, see a disease trajectory, and that's it. That's kind of, what we're taught, the way that we're taught, and what we're expected to learn. How do we manage this? How do we not manage this? And that's what we're going through as an intellectual struggle and an emotional struggle. How do we take care of this patient for this particular illness? Sometimes, and I don't think it's something that we all do knowingly, is neglect or maybe forget about everything else that the patient and their families are going through. Some of it is the physical symptoms of having a critical illness. We know of pain that's associated with so many different illnesses, but there's also dyspnea, constipation, and really, anxiety, depression, the changes in the overall mental health of the patient. There is distress that comes in every other part of your life as well, including spiritual distress. There are those that become conflicted in their faith, maybe are searching for faith now that they hadn't had before, or those that are taking this illness as a strengthening of the faith that they already have. It's looking for forgiveness from a higher power, from your family, from your friends. It's what comes next after I die. How do I process this? There's also the psychosocial distress, the caregiver distress, the families taking care of their loved ones who are now not able to care for themselves in the way that they were before. There is a huge loss of independence that I think hits those that are used to being their own person and doing everything for themselves the most. The financial distress of being in this healthcare system and what that means for them and their family, and thinking about the future of their family. Will they be okay without me? How am I going to handle this? How do I process it? And I think a big overarching reason why palliative care gets involved a lot of times in the hospital, and for those of you that are physicians or practitioners in a hospital that call palliative care, it's driven a lot by illness understanding, recognizing whether or not the patient truly, quote unquote, gets what's going on or has grasped how sick they truly are. Much of that is how we either explain it or what really has been processed. There's an uncertainty about how they want their care to be, and really just this processing of quality of life and what that means in terms of time, and how do I link the two and make them as close together as I can. And what palliative care really does is look at so much of this and everything together in a unique way. So we're really driven by the interdisciplinary team, or what we call the IDT. As you can see, in the center, it's the palliative care team. Palliative care is not just the physician. Is not sustainable if it's just one provider that is doing everything, because our wheelhouse and our lens is so narrow. And in order to broaden it and really get to all of those things that I shared before, spiritual distress, psychosocial distress, we have to look beyond ourselves. So you have your medical provider, whether it's your advanced practice nurse or your physician, the social worker, and spiritual care. It's like the three, I think, most common team dynamics that you'll see at institutions that have palliative care. And then depending on where you are, the ones that I starred are the ones that are institution dependent. So where I trained at Mount Sinai, for example, we had very robust yoga and massage therapy. One of the other hospitals had very robust music therapy. There's child life that gets involved for families, as well as art therapy, other ways to really process what's going on and to process the grief that one is going through and having a serious illness. And then if you're lucky, you have volunteer services that can be ranging from spending time with your families, doulas, people to just really complete and round out the team and really kind of fill in the gaps that we as the rest of the team might not, be able to ascertain ourselves. Now that we know what the team is, the members that really comprise a palliative care team, what does it do and where does it fit and how does it fit? In the model of healthcare that we really know, that I think we're used to seeing, there is a block, there's a wall, there is disease modifying therapy or life prolonging care, there is an illness that has a therapy. And when that ends, for whatever reason it is, it doesn't work, or we've reached kind of quote unquote the end of what we can offer, there's palliative care, which became synonymous then with hospice. It's become, very involved at the end of someone's life experience and the end of their disease experience until the patient passes away. And so we really don't see that trajectory of how the illness is. In the model of healthcare that is more integrated, that really palliative care aims to do, and what we strive to do is that at the first moment of identifying serious illness, at the first moment of recognizing kind of this road that we're going down and this direction that we're headed, the fact that families are now dealing with such a serious illness, such as heart failure or cancer, palliative care is involved. It's throughout the process of having disease-modifying therapy that palliative care is involved, with the involvement growing as the therapy options are coming down. In that way, palliative care can address some of these things that we had noticed before, manage the physical symptoms that are going on, and really help continue that time of processing and help prepare for what might happen in the future and talk about it, plan for it, so that at the end, when the disease-modifying therapies are at the end, and I'm using my mouse here to show the point where there is either no therapies that really can be offered, or the therapies have become burdensome and not in alignment with goals of care, we transition from palliative care to hospice. Hospice is kind of a natural progression of palliative care, then continuing on to death and the bereavement process that follows, with hospice being able to provide support to families after their loved ones have passed away. B is really what we're aiming for, and we're getting there. I think that many programs and institutions have started. There are so many different means and so many different things that have promoted the use of early integration of palliative care. Some of that is a lot of the studies that we've done. There has been multiple studies that have shown the benefit of integrated and early palliative care involvement. Most studies are done in the context of an advanced cancer. What we've seen is that having early palliative care involvement, ideally at the time of diagnosis, improves patient symptoms, improves the quality of care, improves their coping skills. And for the families, those that are dealing with the aftermath of their loved one passing away, it can reduce prolonged grief, it can reduce PTSD, it can help them be able to cope and be able to come to terms with what's happened, although the grief is there and it's hard. It allows people to the best of their ability, prepare and be satisfied with the way that their life during this illness has gone. From another perspective, which is not what I like to, cite and aim for, it has been shown that palliative care earlier does have cost savings for hospital systems. So in a study that was done, it's a meta-analysis called the Economics of Palliative Care for Hospitalized Adults with Serious Illness. Patients that received inpatient palliative care consultation, regardless of their diagnosis, had a cost savings of over $3,000. And for cancer specifically, the cost savings was about $4,000. There's also studies that show that maybe by getting palliative care involved earlier, people live longer, their survival is better. Part of that will go into what hospice talks about, can be because they're not towards the end of their life going in and out of the hospital system. But this was really seen in cancer, which is where a lot of palliative care research has been, advanced heart failure and non-malignant pulmonary disease such as COPD. So I recognize very much that many institutions and many parts of this country do not have robust palliative care. It's a growing field, it's relatively new, it has not been around as long as what we know as medicine, and it's something that's gained a lot of traction. So as much as I would love to be in every single hospital in every single part of the country, we recognize that there is a lot of palliative care that is done and should be done by primary care providers and other subspecialists. So a good chunk of what we do, aside from providing the services to patients themselves, is really education of primary palliative care. That's palliative care that's performed by all physicians of all subspecialties and providers. And it really includes the basics of what I talked about. So basic symptom management, being able to recognize and manage pain, nausea, constipation, anxiety, depression, having those beginning discussions with patients about advanced care planning, their code status, some goals of care, and really in primary palliative care, the transition to hospice should be there. we have to be a little bit nuanced in recognizing that primary palliative care is, because everybody would benefit from having palliative care involvement. And so primary palliative care really allows for every patient going through every illness or going through every life experience to have these conversations and this level of interdisciplinary care, with those that are the most complex having intense involvement of the subspecialist and the referral. And so subspecialty palliative care, which is what I do, is defined by two things: complexity and communication. We're involved mostly for complex symptom management. Not saying that we manage all symptoms, but really when to refer is at the level of complexity. So patients that have a very high symptom burden, that have a management of pain, for example, that requires using opioids very aggressively, using methadone, titrating up of any medication, or really the inability for the primary provider to provide the level of support that's needed for the patient and their family. There are many patients that would benefit from maybe not the physician provider, but the interdisciplinary team. And so a referral to palliative care includes that. So for existential distress, for spiritual distress, and for those that have really complex or challenging goals of care, challenging communication for a myriad of ways, whether it's family dynamics, whether it's the illness trajectory that's happened, whether it's not having a clear understanding about what's going on. A lot of what we're called for, especially inpatient, is for communication. It's something that we are trained extensively in to do, and it's something that we can help facilitate. So helping the families and the providers many times understand the illness and coping with that understanding, and then transitioning of care, especially when it's not as straightforward as just going to hospice. And all of this can happen throughout the course at any point of the critical or serious illness. What I really wanted to share briefly, though, is some tools that can be useful, I think, for primary palliative care. These are things that we'll share with other providers, and just some definitions of the paperwork that's involved and what we provide to families and talk to them about. So the first thing that I wanted to define was advance directives. So we've heard of advance directives. We help patients go through them. We always ask if you have one. However, we don't necessarily know what's in it and what's not. So an advance directive is a legal document. In the advance directive, patients share their healthcare preferences, whether it's not to be hospitalized, whether it's their code status, whether it's how they feel, so that if they're at the point of illness where they are not able to communicate that with you directly, this has been documented by the patient while the patient had capacity and was able to share this. In an advance directive, it might include a healthcare proxy. Not every advance directive has a healthcare proxy. And this can be done for patients at any stage of a serious illness. And it's something that really, if you are a primary care provider or any sort of subspecialty provider, should be encouraged so that everyone has an advance directive. A durable power of attorney for healthcare, which is also known sometimes as a healthcare proxy, is a really defined piece of paper, and it's a really defined role. It's a decision maker that is assigned by the patient in the event that a patient is incapacitated and decisions are to be made. These can be decisions that are not documented in an advance directive. So we don't know what the patient would want in this scenario, and we are looking to you as the advocate and the trustee of this patient who knows them well to be able to tell us what they may or may not want in this particular illness instance or in this illness overall. If a patient does not select a healthcare proxy, the decisions fall to a surrogate decision maker, and those laws vary by state. What I know the most obviously is New York's laws, and New York has very specific surrogacy laws that were defined under the Family Healthcare Decision Act, which list in order of ranking who would be the decision maker in this illness. For example, what I'll share is that after spouse or domestic partner, we always get stuck at some point where it is living children. And our gut and our go-to instinct is to go to the one child that really we've communicated with and we know. However, what we fail to recognize is the law is very clear that the surrogacy falls to all the children, regardless of their involvement in their loved one's life, in their family's life throughout the course of this illness. So what we encourage patients to do, and healthcare proxy forms also vary by state or institution, is to find someone that they know and trust, someone that they've sat down with and had these conversations with that knows what they may or may not want, and someone that they feel like would be the best advocate for them. This is also something that should be done at any stage of serious illness, ideally in the beginning, and it should be something that all adults have. To help facilitate some of these conversations, I wanted to highlight a couple of websites that we'll use that have resources that can be very helpful to families. So I'm gonna click through them and let's see what happens. The first one is 5 Wishes. So 5 Wishes is a tool that really just prompts the conversation. So it has some prompts that are there. It helps patients talk about advanced care planning. And it is also something that can be documented and used to share. So I think it can be made appropriately legal in the way that it needs. So for individuals and families, there is resource guides. There are conversation guides that can be bought by a practice or something that can help for families to start this conversation on their own. So it is an advanced directive document. It just kind of helps you know, what do I talk about? How do I talk about it with my family? The other one is something that was done by the Advanced Care Planning Decisions that it's similar. It's a nonprofit that helps to have these conversations and really helps patients, clinicians, administrators have these conversations and document what they're talking about. And it's a way to empower people. What we want to do is encourage the conversations that can be quite awkward or uncomfortable for families to have. The next set of documents that we have are the documents that are specifically for patients that are towards the end or in more critical stages of their illness. The one that we're going to focus on is called the Practitioner Orders for Life-Sustaining Treatment, or a POLST. In some states, such as New Jersey, it's called a MOST, or Medical Orders for Life-Sustaining Treatment. These are, as it says, orders. This is done with the healthcare provider. So while the other documents were legal documents and a healthcare proxy really can be done with anybody, the POLST and MOST need to be done with the physician provider and need to be discussed with them and signed off together. So these are medical orders. They reflect the discussions and decisions that are made about healthcare. They can travel across healthcare settings, which is nice. So from a nursing facility to a hospital to a clinic to a rehab center. And it's really targeted to patients with serious illness, frailty, or a prognosis that we believe to be less than or about a year. It's done in conjunction with a physician or a qualified professional, and it's honored by emergency medical services, which is really what I emphasize with patients a lot. They are brightly colored, and I misspoke earlier. So the New York ones are called the MOLST, the New Jersey ones are called a POLST, and then other states use other variations, either MOLST or POLST. Most states have them very brightly colored. What we tell families after we fill them out, and this is not all of it, they're double-sided. We go through them, that they should be put somewhere that's easy to find, whether it's the fridge, above the bed, or someplace that if for some reason emergency medical services was called, they could see it easily because they will honor it. So in a really high stress situation, going through a drawer to find it can be really hard to do. You don't think about it, don't know what to do, and there are a lot of emotions, and having things written down in advance can really help put you at ease. Remember that you've had this conversation, that you know what you want to do in this scenario, and that we know as a team what matters most to this patient or your loved one. So it goes through different things. For the most part, they all go through similar kind of things. The code status is always there. Whether or not some of them go through artificial fluids, such as IV fluids and G tubes, artificial nutrition, hospitalization in general, and who the decision makers should be. This still needs a healthcare proxy, but it can at least help remind us who to look for. And then if you see at the bottom of the pink one, which is the New York ones, it talks about who the advanced directive, like what other forms have been done for this patient. They should all be together. New Jersey one, which I think is a little bit blurry. There's a section specifically on there that I've noticed is not in the New York one that actually says that like my healthcare proxy cannot change the decisions that I have made unless, or yes, they can override the decisions that are made. Knowing that people might be in specific illnesses, their wishes might have been that if it was instant X, that was able to be fixed with an intervention that I might not have wanted in another instance, I would allow it. So now we've talked about primary palliative care, what we hope it will accomplish, all the paperwork that's involved, what we can do, and now really how do we do it? How do we have this conversation with our patients? How do we start talking to them about their wishes and preferences? Because maybe I was taught, maybe I haven't done it in a long time, I'm not sure. I think that part of what I recognize doing this sort of subspecialty training is that there is an art and a skill and teachable ability to communicate effectively, and it's something that I, as someone who thought I was a good communicator, had a lot to learn. So there have to be some tools out there. There has to be something educational that we can do. So Vital Talk, which I don't know if my mouse will allow me to click it, is a resource that you guys can go on the website that really teaches communication skills. I think it's the basis of a lot of the training that's done in palliative care programs around the country. It has communication skills for the individual. It has courses that can be brought to your institution for the outpatient setting or the inpatient setting. There are different variations for it. And really right now, given the COVID era that we're in, there are free resources that are solely dedicated to talking to patients and families about COVID-19, what that means, what the serious illness means, not being able to visit your loved one, not recognizing what's going on, and really talking about the uncertainty of the illness and what to expect. A quick pause here just to see if, before I go into talking a little bit about hospice, if there was anything that popped up. I'm just going to take a look at the chat box. So I don't see any questions right now. So we're just going to go towards the end of the talk, which was talking about hospice. And this is a very brief overview of what hospice can do, and hopefully it can be helpful. Hospice is this gold box right here. It is the end of disease-modifying therapy. It is just a part of someone's life that is just so fragile and so precious that hospice really aims towards giving patients the best quality of life that they can have in the last weeks to months of their life. It's a benefit under Medicare. It's also in most commercial insurances. It is not a location of care. I think that's something that we really hear a lot. We're going to hospice care with an ill-defined kind of where that is. The focus of hospice is comfort focused. It is for patients that have an expected prognosis of less than or equal to 6 months if the disease runs its typical course. And I will go into kind of what happens if the disease does not run its typical course. So because the goal at that time is truly comfort focused, disease-directed therapies that are not for symptoms are stopped. So such as chemotherapy or a surgical intervention are stopped. The median length of stay, though, despite the fact that it's geared and directed towards patients at the end, the last 6 months of their life, is actually about 3 weeks. I think it has increased from 19 days to 21 days, but patients really come to hospice at a very short weeks of their life. In order to have this prognosis, 2 physicians need to attest that the prognosis is the way that it is the last 6 months. And one of those physicians is the hospice director. Here's the hospice team. The hospice team looks very similar to the interdisciplinary palliative care team because it is a nice kind of bridge towards hospice. A hospice team involves a physician, but really hospice, when developed by Cicely Saunders, is really a nurse-driven team. So it is comprised of nurses, social workers, there's therapists, home health aides, spiritual counselors, bereavement, child life, etc., that really comprise it, with a physician that's really just oversight for it all. The person that you're really going to be interacting with the most if you have a loved one in hospice or are thinking about it is the nurse that that's taking care of you, and the physician is here for support. The goals, as we talked about, are very similar to what palliative care goals are: symptom management, addressing any emotional, spiritual needs, providing support to the family, and then bereavement services. So some of the challenges that we face, going back and seeing the fact that, we have to prognosticate now. We have to be able to tell ourselves and a family where someone falls in critical illness. Is this really the last 6 months? Is my patient hospice appropriate? I don't know. The challenge that we've seen, is the fact that cancer is the green line here, has been the clearest. There is cancer receiving disease-directed therapy, and then there is a moment where that either fails the patient or it does not align any longer. The burdens have outweighed the benefits. And then from there, there is unfortunately a very quick decline. And so that's why I think cancer becomes the most common, or one of the most common illnesses that we see in hospice. The most challenging of the two of this is organ failure. An example of that is heart failure, where we see and what we explain to patients is this up and down, where you have moments of illness where you are decompensated, so decompensated heart failure, for example, or a COPD exacerbation, and then you quote unquote bounce back. You come back. However, if you can tell on the graph, it's not to the level that you were before you decompensated. What we find challenging is how do you decide which one of these decompensations is the decompensation that one cannot bounce back from or will really not be able to improve from, that rehab will not support, or that has really taken that toll on the patient's body? Dementia and frailty is another one where the decline is quite slow and it's confusing. We are dealing with multitudes of different aspects that have changed in someone's life, whether it's an illness, an infection, whether it is other comorbidities that have now developed, and how do we put that all together? So recognizing that we're not all basing this on one illness, people have other illnesses that go along with it that can really impact also what's going on. In order to help support that, there is eligibility criteria that exist. This is something that can be looked up from the Centers for Medicare and Medicaid Services for many illnesses. The two examples I just wanted to highlight was Alzheimer's dementia in specific and pulmonary disease. Alzheimer's dementia, the eligibility criteria is a FAST score of 7A. So with one medical complication such as aspiration pneumonia or something else in the last 12 months, a hospitalization, a fracture, something else that's happened. And then pulmonary disease has criteria for lung disease that can help us understand better and remind ourselves where we are in this illness. As I highlighted before, hospice is not a location of care, but it's a model. So the model of providing comfort care or comfort-focused care, and the next step and the next question after that should be, where would we provide this care? Where is the best place for this person? Where is it that they would like to be taken care of, and how feasible is it? So routine hospice care can occur in a lot of settings. The most common setting is home. There are options for skilled nursing facilities. It's based on the nursing facility that you're in and their relationship with the hospice agency, and then the hospital. However, hospital-based hospice care is a specific kind of subset of what hospice care is. Routine care is care that can be administered at home, and I'm going to go through specifics of what that is. But hospital-based care is really for those that have uncontrolled symptoms, and in some cases, respite care. So having someone who's at home come to the hospital for a short amount of time in order for the family to get some rest or a reprieve for a little bit to help with their kind of emotional processing. So home hospice will provide medications. So oral medications, rectal medications, sublingual. It will not routinely do IV medications. That's a common misconception. It will provide durable medical equipment, such as a hospital bed and a shower chair and wound care supplies, and visitation. So I think what people expect, or sometimes what I've heard are the expectations, is 24/7 care at home, which is not the model of how hospice care is provided. So it's about weekly visitation, and it can be increased from various members of the care team based on the symptom needs the patient has. It can provide short-term continuous care. So say you're at home and something has happened and there are needs, and we want to take care of someone at home, there's a short amount of continuous care that can happen, either a nurse coming in or an advanced practice nurse to help control symptoms more aggressively. And there are a small amount of home health aid services that happen. I think in my most recent experiences, it's about 10 hours a week. It's about 2 hours a day. And all of this means that the majority of day-to-day care falls on the family, and there is telephonic support from the hospice team. The family is educated on the patient's care needs. The family is educated on how to administer medications, and the family is the primary person to help their loved one get through this illness. Whether or not there are other, support that's offered, a lot of it is patient specific. Facility-based hospice is a hospice service that's provided in the assisted living facility, in skilled nursing, or in a dedicated hospice facility. And that's something that I was saying before, check with the nursing facility, the relationship with the hospice agencies. This patient receives care from the staff at the facility, still gets their visitation from the hospice team. The hospice team works in conjunction with the staff at the nursing facility, including the physician. And so for the family, this means that the day-to-day care doesn't fall on them. The family can avoid the role in some ways of being a caregiver and really can just focus on being a family member and a loved one. There are many families that this works well for them and works better for them. It just helps them process. The last one is hospital-based hospice, which is inpatient care. The inpatient hospice is a level of hospice care that's provided in a hospital setting. It's not available at every hospital. It is available at hospitals that have relationships with hospice agencies. And patients end up there because their symptoms are uncontrolled. It's something that cannot be managed at home or the facility that they're in, and they require a higher level of care. That is the hospital. However, an inpatient hospice is a hospital bed that's really focused on the goals that are there, that is in alignment with those goals. It can be also for medications that have to be given in the hospital setting, such as IV medications that cannot be done at home or at the nursing facility, or for some patients that have a reversible illness that they want to try to reverse, that is in alignment with the goals of care. For example, a urinary tract infection that the family would like, or the patient has previously stated would like to focus and try to reverse if possible. It can also be used for sudden deterioration that requires intensive nursing care because that cannot be provided elsewhere. And really, a lot of it is short-term care. So after the patients are stable, they transition either back to home or to a facility to continue routine hospice care. So as a result, if you enroll your patient in hospice, or if your loved one is enrolled in hospice during a hospitalization, their enrollment is typically done in the last 1 to 2 days of hospitalization if they do not meet the criteria to be inpatient hospice. Lastly, these are really common questions and misconceptions of hospice that I just didn't fit into the other slides before. So as I was mentioning earlier, we said it's 6 months. So what if the prognosis is not 6 months? And I misspoke, it's greater than 6 months. Does the patient get kicked out after 6 months of hospice? And they don't. That's where face-to-face reassessments are done by physician providers or advanced care nursing to determine at that 6 months that the patient has declined and still requires and is eligible to continue hospice, and then it's continued enrollment. So there are intervals that are done after that. Hospice just hastens death. And no, what I had mentioned earlier is that prospective studies actually show that hospice may improve survival, possibly because patients are not being cycled in and out of the hospital and are really staying in a care setting that is more valuable to them. And then in order to enroll in hospice, patients lose their primary care physician. We have patients, or we've taken care of patients that we've had for many years. I'm very early in my career and cannot say that I have that, but patients are afraid to lose their primary care physician. And no, the hospice team has a medical director. However, if your primary care physician is the person that you trust, they can still be your primary care provider. And they work with the hospice agency to provide you care. So conclusions, and then we have some time for questions. We've seen that early integration of palliative care services during the course of an illness benefit the family, the patient, and the care team. Palliative care and hospice are different, but they do transition into each other. Conversations about treatment preferences should occur as early as they can in the outpatient primary care setting, and there are some resources in the slides below about that. The hospice benefit is known, but we don't take enough advantage of it. Our length of stay is very short. And really early involvement of hospice care can decrease the hospitalizations at the end of life and possibly improve survival. So with that, I'm going to I have a few minutes to answer any questions anyone might have, and I know there were a few.
Thank you so much, Dr. Piracha. I'd be happy to read some of the questions. We have a couple from the Facebook Live as well.
Sure.
Firstly, I would like to thank you for sharing some of those resources, the 5 wishes and Vital Talk. It allows for those who may be currently dealing themselves with a family member and it being very emotionally daunting, and an opportunity to navigate through those questions. And it also provides a great resource for us to kind of stay ahead or step ahead and to talk about these serious topics as a way of preparing for the possibility of these. So those will be posted on the IMANA Education website, the resources that Dr. Piracha shared with us today. In addition, this webinar is being recorded. And the webinar, along with the PowerPoint, will also be posted on IMANA Education website in case you would like to refer to it later or share it with others who may find it beneficial. In regards to some of the questions, you mentioned that you are most commonly called for communication. How does palliative care specialists, how do they work alongside with the patient's provider? Would we consider them to be more of a liaison between the patient and the provider? Do they speak on behalf of their quality of life? What if there's a difference of opinion? How do they, go about working together as a team in that way?
That's an excellent question. So we are consultants, just as you would call a cardiologist or a pulmonologist for their skill set. Really, we work in conjunction with the team. We do not take over. A lot of the conversations that we do, and I think a really common example that many people that work in a hospital might see is kind of the family meeting. So it's getting all the parties together that really have been involved in this family and patient's care. And some of what we do in the beginning, before even talking to the family or the patient themselves, is talking to the providers and helping everyone understand where we really are. I think that having done internal medicine and having done pediatrics, we get very engrossed in what we are good at. And sometimes you need an outside body to take that step back to help you see the bigger picture. So we start there and then bring everyone together. I think the most ideal scenario and what we consider like the best family meeting is the one where the palliative care physician talks the least. Our job is to encourage and to help bridge the communication, make sure that if something is said that either party does not understand, either the family or the physician or the team, the other team, that we get everyone on the same page. Sometimes it's helping to deliver a serious message, such as the fact that this illness is critical. And sometimes it's just to help families cope. So there are some times, and there are many times where we do interact, we see the families alone, we provide the support. However, in conjunction with the team, we're working alongside of them, sometimes bringing together specialists that haven't been together before, that are both doing their thing and now helping them to do their thing together and to see what that benefit is and what the risks are. So it's a nuance. Sometimes you have to really probe and understand what are we here for, and what are we doing right now, and how is that benefiting this person that's in front of us right now.
Yes, absolutely. Thank you so much for that. I'm sure it is quite subjective in regards to each patient and their family, and technically their their patient experience, that they are how they are coping.
Right.
Another question we had was in regards to hospice. In terms of explaining prognostication to the patient or to the family, you showed an excellent graph of, a very visual depiction of the process of cancer, and then the comparison with that with organ failure, and then you mentioned the frailty and dementia. Which, from a physician standpoint, you can kind of see how that process works. But tying into the, the psychosocial and the spiritual, how do you go about explaining this, to the patient or to their families in terms of what they should be expecting, or, maybe not getting their hopes up, or, in regards to the, the ups and downs in regard to the failure. How do you go about that in terms of a communicative aspect?
I think the most success that we've had, and Vital Talk has a lot of resources about that too, but some ways that we'll do it, sometimes this graph, the blue one in particular, I will draw that out. Sometimes I will kind of demonstrate it. And really many times if you ask the families what they've been noticing, they will tell you. And if you're like, this is what we see is sometimes when you'll hear a story of, my mom went to a hospital for this and she came back, and after she came back, she's not eating the way that she was before. And then she ended up in the hospital again. As they share it more, we validate what they've heard. And I think really the biggest thing that we want to make sure we do is it's not inadvertently blame the patient for what's happened. So it's understanding the fact that this is the way that we see, for example, dementia progress. As time goes on, we can expect certain things to change. You want to make sure that the family that you're communicating with, what they want to know. Sometimes everyone wants to know the nitty-gritty details, and we have to recognize the uncertainty of an illness. And sometimes they just don't really want to understand, or not that they don't want to understand, that's not the information that they need to process. So it's less of lecturing it at them. I think it's more of asking them to share with us what they've seen, and then helping to affirm and validate that that is not surprising to hear, and that we may see things shift in a different way. And after every time you say that, you pause. That's new news to share. How does that make you feel? And should we go on and talk about the next thing? So I think for me, I understand things more through pictures. I think that's the way I process. And so I find an image like this very helpful. Sometimes it's also, I know these are very vague answers, but also very family specific about what they want to know. I think that we just want to make sure that we're not inundating them with numbers. And the biggest thing is when they want to know how much time do they have left, not giving them like a date and saying, well, you have 3 months to live, because they will hold on to those words. And if it's shorter, if it's longer, that is, the mistrust is there from the beginning then.
Yes, we tend to see that in terms of a layman's term of having to grapple with how much time do you have to live, or things that we see in the media about that. But that is something in which, from a medical perspective, is territory that that should be avoided. As you mentioned, that there are cases of people who end up exceeding the time of hospice, and so there is always those possibilities. There is another one last question that we had in regards to the research. You mentioned multiple studies that talked about the benefit of early palliative care, that it improves patient symptoms, quality of life, and coping skills. Just kind of one last thing to kind of tie in the importance of your specialty is, why do you think palliative care has been shown to benefit not just the patient but the family, in terms of showing that an illness is so much more than just the physical aspect of it? How have you, maybe from your own personal experience, noticed fulfilling their emotional or spiritual or psychosocial needs have improved or altered their route in terms of their medical condition? How have you, on a personal from your personal experience, noticed that within your field?
A couple of examples. I think one of them, for example, is the family. I've had quite a few families that it is their parent. It is someone who spent their entire life independent, doing everything on their own, and declined suddenly for many reasons. And then from there, the family, whoever it is making the decision, thinking of it what they would want for themselves. And really, mom has always done everything on her own. She gets up every day, she goes to the store, she does what she has to do. She hasn't asked for help from nobody. She worked her whole life, and she would not sit still. Or what a loved one sees is, I want my mom around forever, or as long as it can be, and we should do that. So what we help to do is bridge that and take the voice and make it mom's voice again, and say, well, okay, mom is here. If mom could talk, how is mom going to tell you that she would want? And like a lot of families, it's helping them not to feel the guilt of the decision that they might be making. It's hard to say, okay, my mom would not want to be in an ICU in her last days of life. She would not want, quote unquote, everything done. And that, I think, is something that we really helpful with, is helping that early grief and helping them understand and be certain in the decision that in their heart they want to make, and they're not able to make it for a reason. And I think some of the examples that I think help the providers the most are those that are younger. I've had experiences with the young adults, that are in their 30s, like myself, or in their 20s, and are really just in a place where now their parents are struggling with losing them or watching their child suffer. And it's helping the parents cope with the fact that, this is horrible. Their child is suffering in front of them. And how do we help you process that, to continue to not only be their parent, but to be the person that we turn to help decide what to do for your child, a role that you might not have been doing for the last 10 or 12 years. And I think those are the examples that really stick with me the most. And I think one thing, and to tie into the question that you had typed out also, is in COVID-19, we really saw, especially in New York City, what palliative care could and should do, and really helping us as providers navigate a very serious illness, and helping families grapple with the fact that we don't know much about what's going on. What we know is that what we see in front of you, and you're not here. So we have to maybe help push conversations that we wish we had time to have in a very condensed way. So I think what we just saw in the last few months was just like everything on hyperdrive.
Thank you so much, Dr. Piracha. I don't want to take up too much of your time. We are at the end of the webinar timing at this point, but we would love to have you back in the future. This is very, much needed topic for our community, and I'm sure that other health professionals and students would love to hear more. So we would love to have you back if you are able to. For those who are listening, as we mentioned earlier, this webinar is being recorded, and we will share it along with the PowerPoint on the IMANA Education website. We have several webinars lined up for this summer. We have one coming up next Monday at the same time with Dr. Irfan Sheikh, who will be discussing the basics of stroke. So we hope to have you tuned in at that time as well. Thank you so much, Dr. Piracha. Jazakallah khair. If anyone has any further questions, you can contact IMANA Education and we can reach out to Dr. Piracha on your behalf. So we'll go ahead and close the webinar. Thank you again, and we'll end with Surah Asr. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. By time, indeed, man is at a loss, except those who believe, who do righteous good deeds, who recommend one another to the truth, and who guide one another to patience. Ameen. Thank you again for listening in. Assalamu alaikum wa rahmatullah.